Case 1. Michael Swango, the poisoner in the white coat. Michael Swango looked, on paper, like exactly what American medicine wanted. He was handsome. He was articulate. He was a former decorated United States Marine who had gone back to school and worked his way into medical education through what appeared to be genuine discipline and ambition. When he entered the medical program at Southern Illinois University School of Medicine, his classmates found him charming and serious. He seemed destined for a strong career. The notebooks he kept, however, told a different story. Alongside the anatomy diagrams and pharmacology notes that filled his classmates' notebooks, Swango's pages contained something else. Detailed, almost affectionate accounts of car crashes, industrial disasters, and violent deaths. He collected news clippings about mass casualties. He studied the effects of poisons, particularly arsenic, with an intensity that went considerably beyond any academic requirement. His peers noticed it, filed it under the category of dark humor, and moved on. Medical school breeds a certain gallows sensibility. Nobody looked harder. They were looking at the early formation of a serial killer, and they didn't know it. In 1983, Swango began his surgical internship at Ohio State University Medical Center. Within weeks, something was wrong on the floors where he worked. Patients who had been recovering well began suffering sudden, violent, and medically inexplicable events. Seizures with no prior history. Respiratory arrests in people with no lung conditions. Cardiac events in patients who had been stable. The incidents were clustering in a way that defied statistical probability. And they were clustering on Michael Swango's shifts. Nurses noticed. They compared notes quietly, then less quietly. One nurse walked into a patient's room and saw Swango injecting something into an IV line. Minutes later, the patient suffered a near-fatal respiratory arrest. She reported what she had seen. The hospital conducted an internal review. The review found no hard proof. The complaints were dismissed. The patients continued to die. Ohio State eventually removed Swango from the program, not for the mounting suspicious deaths, but for poor academic performance. He left without facing a single criminal charge related to the bodies he had been leaving behind. He reappeared in Quincy, Illinois, as an emergency medical technician, a position that, again, gave him access to vulnerable people and to medical substances. In Quincy, he killed more quietly for a while, but his compulsions extended beyond his patients. He began bringing food and drinks to his EMT colleagues. Donuts, iced tea, the kind of gesture that, in any normal workplace, reads as simple kindness. One by one, his coworkers became violently ill after consuming what he had brought. The symptoms were consistent and severe. Intense nausea, cramping, debilitating gastrointestinal distress. An investigation was opened. The food and drinks were tested. They were laced with arsenic. Michael Swango was convicted of poisoning his coworkers. He was sentenced to 5 years in prison. He served 2 years for a mass poisoning with arsenic. Upon release, he embarked on what can only be described as a campaign of systematic identity fraud, executed at a level of ambition that should not have been possible. He changed his name. He forged documents. He fabricated references. He constructed an entirely new professional history and submitted it to medical residency programs, omitting the small detail that he was a convicted felon who had poisoned multiple people. It worked. He was accepted into a residency at the University of South Dakota. The pattern began again. Patients started dying. When his real identity and criminal record were eventually discovered, he was fired. Once again, no criminal charges were filed for the new deaths. He moved to New York and lied his way into a residency at Stony Brook University Hospital, this time using a carefully constructed story about having been framed by jealous colleagues. He was convincing enough that the program accepted him. Patients began dying again. He poisoned a patient named Baron Harris with a fatal injection, a crime he would eventually admit to. When his cover unraveled in New York, Swango simply vanished. In 1994, using a forged resume and fabricated letters of recommendation, he secured a position at a remote missionary hospital in Zimbabwe. The setting was his most dangerous operational environment yet, understaffed, under-resourced, geographically isolated, and without the institutional oversight mechanisms, however weak, that had existed in his American postings. Staff at the Zimbabwe hospital gave him a nickname, Dr. Death. They watched their patients die in numbers that made no clinical sense. The symptoms, paralysis, seizures, sudden respiratory collapse, pointed clearly to poisoning. Local doctors and nurses tried to raise alarms. The isolated setting and the systemic deference to a credentialed Western physician slowed every attempt at intervention. The net began closing from an unlikely combination of directions. The dean of Stony Brook who had fired him, investigative journalists pursuing the story, the producers of the television program 2020 who had been following the case. Together, they brought the international scope of Swango's killing spree to the attention of federal authorities. In 1997, FBI agents arrested Michael Swango at O'Hare International Airport in Chicago. He was waiting to board a flight to Saudi Arabia, where he had already secured another medical position. Initial charges were fraud, lying on his applications. Prosecutors then spent 3 years building the murder case, working with authorities across multiple countries and pursuing the exhumation of his American victims. In 2000, faced with the death penalty in both New York and Ohio, Swango pleaded guilty. In a voice that witnesses described as completely devoid of emotion, he admitted to murdering 3 patients in New York and 1 in Ohio. He admitted to poisoning numerous others over the course of his career. The exact number of people he killed across the United States, Zimbabwe, and potentially other countries remains unknown. In exchange for his confessions and the removal of the death penalty from the table, he was sentenced to 3 consecutive life terms without the possibility of parole. As of August 2026, Michael Swango is 70 years old. He is incarcerated at ADX Florence in Colorado, the federal supermax facility that houses the most dangerous prisoners in the United States. He has not spoken publicly in decades. The Swango case is, in its systemic dimensions, as disturbing as its individual crimes. At multiple junctures, Ohio State, South Dakota, New York, Zimbabwe, institutions that should have caught him either failed through incompetence, chose institutional reputation over patient safety, or lacked the coordination mechanisms to connect the dots across jurisdictions. A convicted poisoner kept his white coat because nobody built the system to take it away. Before we get into the second case, if you're new here, welcome to Daily Crime Archive. This channel covers cases that deserve more than a surface-level overview. We go deep on the investigation, the legal proceedings, the systemic failures that allowed these individuals to operate, and the questions that don't get answered in a 2-minute news segment. No sponsors shaping what we say. No algorithm chasing shock value. Just the cases, researched and told with the weight they deserve. We are a new channel. That means your subscription matters in a direct and concrete way. It affects how YouTube's algorithm treats us and how many people find this content. If you're watching this and you're not subscribed, hit the button and turn on the bell right now. Now. Case 2. Case 2. Harold Shipman, the most prolific serial killer in modern history. In Hyde, a small market town in Greater Manchester, England, Dr. Harold Shipman was not merely a physician. He was a fixture, a known quantity, a man who had been present at the births, the illnesses, and the deaths of generations of families in the community. He had a reputation for being thorough, for making house calls when other doctors wouldn't, for having the kind of unhurried, attentive bedside manner that most patients had stopped expecting from general practitioners. People waited longer to see Dr. Shipman than they waited for other doctors in the area, and they waited gladly. For over 2 decades, he was exactly the doctor a community like Hyde would have held up as an example of what the profession should be. His method was straightforward and devastating in its simplicity. The vast majority of his victims were elderly women, patients who trusted him completely, who were accustomed to his visits, and who lived alone in homes where an unexpected death would be attributed, without much scrutiny, to the ordinary causes that claim elderly people. He would arrive for what appeared to be a routine house call. While alone with his patient, he would administer a fatal overdose of diamorphine, medical-grade heroin. He would then wait for them to die in the quiet of their own living rooms or bedrooms. Afterward, he would alter their medical records, changing the documented history of their health to make the death appear consistent with existing conditions. In many cases, as their attending physician, he was also the one who signed the death certificate. He was the killer, the cover-up, and the official record, all in one person. This system worked, without interruption, for approximately 23 years, from 1975 to 1998, across hundreds of patients. The true scale of his crimes is among the most difficult figures in criminal history to fully absorb. The formal public inquiry that followed his conviction, known as the Shipman inquiry, led by Dame Janet Smith, officially confirmed 218 murders. The inquiry also concluded that the actual number was likely closer to 260. The victims were almost all elderly, almost all women, almost all patients who trusted him and had no reason not to. He was not erratic. He was not impulsive. He was patient, methodical, and consistent, killing one person at a time over nearly a quarter of a century, with no apparent acceleration, no escalation, and no period of dormancy. He maintained his practice, his community standing, and his reputation throughout. The question that criminologists, forensic psychiatrists, and investigators have never fully resolved is why. Shipman never offered an explanation. He never confessed. He maintained his innocence from the moment of his arrest until the moment of his death. The absence of an obvious motive is part of what makes his case so difficult to place within the frameworks that tend to organize our understanding of serial killers. There was no overt financial benefit in most cases. There was no apparent sexual component. There was no escalating pattern that suggested building compulsion. What some analysts have proposed is a God complex of a specific and extreme variety. Not the narcissism of a doctor who overestimates their own healing ability, but the active, deliberate exercise of the ultimate power. The power to end a life, at a time of his choosing, in a place of his choosing, with complete certainty that no one would question it. The power, in other words, to be the last authority on whether a person lived or died. If that is correct, and it remains a theory, not a confirmed explanation, then Shipman's practice of medicine was, from some point in the 1970s, less about healing and more about the systematic exercise of that power. Every house call was, in part, an exercise in deciding whether today was the day. What brought him down was not surveillance, not a tip, not investigative work. It was arrogance. His final victim was Kathleen Grundy, an 81-year-old former mayor of Hyde, a woman of some social standing and financial means. Shortly after her death in 1998, a will appeared. It was clumsily typed, badly formatted, and legally amateurish. It left Kathleen Grundy's entire estate, nearly £400,000, to Dr. Harold Shipman. Her daughter, who was a solicitor, read it and knew immediately it was forged. She went to the police. The investigation that followed began as a fraud case and rapidly became something far larger. Kathleen Grundy's body was exhumed. Toxicology found lethal levels of diamorphine. Investigators then pulled the death certificates Shipman had signed over the years and discovered an impossible statistical pattern. His patients, particularly elderly women, died at a rate that no legitimate medical practice could explain. Exhumation after exhumation told the same story. In 2000, Harold Shipman was put on trial for 15 counts of murder, a sample of the cases where the evidence was most solid. The jury found him guilty on all 15. The judge sentenced him to 15 concurrent life terms, with a recommendation that he never be released, noting that Shipman had caused untold damage to the doctor-patient relationship in Britain. The formal inquiry took years to complete and found catastrophic failures in the oversight mechanisms that should have caught Shipman decades earlier. On January 13, 2004, the day before his 58th birthday, Harold Shipman hanged himself in his cell at Wakefield Prison. He took every explanation with him. As of 2026, his name remains in British consciousness as a synonym for a specific and terrible kind of betrayal. The betrayal of the most vulnerable, by the person they trusted most, in the places they felt safest. Case 3. Farid Fata. The cancer lie. The moment a doctor says the word cancer, the world changes. For the patient sitting in that office, the floor shifts. Time reorganizes. Everything that seemed important an hour ago becomes secondary to the question of survival. The relationship with the oncologist who just delivered those words becomes, immediately, one of the most important relationships of that person's life. You trust what they tell you. You have no framework to doubt them. They have the test results, the imaging, the credentials, the language. They are the person between you and death. Farid Fata understood exactly what that moment felt like to a patient. He had delivered it hundreds of times. He also understood that it was the single most exploitable moment in all of medicine. Fata built a substantial medical empire in the affluent suburbs of Detroit, Michigan. 7 clinics, an in-house pharmacy, a practice that, at its peak, was treating thousands of patients. He was prominent in the community, respected by peers, and presented himself as a compassionate specialist, a man who combined medical excellence with genuine concern for the people under his care. The reality was this: Farid Fata was diagnosing healthy people with cancer they did not have, and then subjecting them to years of chemotherapy they did not need, in order to bill Medicare and private insurance companies for treatments that served no medical purpose. The diagnosis was a weapon. It delivered psychological devastation, fear, grief, the complete reorganization of a person's sense of their own future, as the precondition for the fraud that followed. Families were shattered. Lives were restructured around treatment schedules. People quit jobs. Relationships collapsed. All of it predicated on words from a doctor that were simply, deliberately, knowingly false. Then came the chemotherapy. Chemotherapy is one of the most physically demanding treatments in modern medicine. It attacks rapidly dividing cells, which is why it targets cancer cells, but also why it damages the immune system, the digestive tract, the hair follicles, and numerous other systems. The side effects are severe. The drugs are toxic. The process is grueling. Patients undergoing legitimate chemotherapy endure it because the alternative is worse. Fata's patients endured it because he told them they had to, because he told them they were fighting for their lives. They were not fighting for their lives. They were healthy, or they were in remission, or they had conditions far less serious than the ones Fata had described. Their immune systems were destroyed by drugs they should never have received. Their teeth deteriorated. Their bones weakened. Their organs sustained damage. Some developed secondary conditions as a result of the treatment. He was not treating a disease. He was inducing one. He ran his clinic with the efficiency of a production operation, sometimes processing up to 50 patients per day in sessions so brief that substantive clinical conversation was impossible. Each IV drip, each infusion, each injection was a billing event. He deliberately prescribed the most expensive drugs at the highest possible doses, not for therapeutic reasons, but to maximize reimbursements. He treated a man for a tumor that did not exist. He treated another for 2 different types of cancer when he had neither. He told a woman whose cancer had been in remission for years that it had returned, condemning her to additional years of unnecessary treatment. In perhaps the most morally grotesque example, he administered chemotherapy to patients who were actively dying, spending their final weeks in agony, in a clinic, under treatment they did not need, while he billed their insurance policies for the privilege. The man who brought him down was not a detective or a federal agent. He was an office manager. George Karaji was hired to manage the administrative operations of Fata's practice. What he saw when he began looking at the records was impossible to ignore: falsified diagnoses, treatment volumes that made no clinical sense, and a constant flow of terrified patients being processed through a system designed not to heal them but to extract money from their suffering. Karaji began quietly collecting evidence. He documented what he saw. Then he took everything to federal authorities. The FBI raided Fata's clinics in 2013. The full scope of the operation was confirmed. Investigators identified more than 553 victims and documented fraudulent billing to insurance companies exceeding $17 million. At sentencing in 2015, victim after victim stood before the court and described what Fata had done to them. Not just the physical damage, but the years of fear, the treatment of a disease they never had, the permanent changes to their bodies, the time stolen from their lives. The judge told Fata, "You did not just shame yourself, you shamed your profession." He was sentenced to 45 years in federal prison. As of August 2026, Farid Fata is incarcerated at a federal correctional institution in South Carolina. His medical license has been permanently revoked. We're 3 cases in, and already the range of what a medical credential can be used to do is extraordinary. A systematic poisoner, the most prolific serial killer in modern history, a doctor who told healthy people they had cancer. 7 more cases to go, each one different, each one with its own specific kind of horror. If you're watching this on Daily Crime Archive and you haven't subscribed yet, do it now. We're building something here, and your subscription is what makes the algorithm show this to more people. It takes 5 seconds. Drop a comment telling us which of these cases you already knew, and which one is hitting different than you expected. We read everything. Let's keep going. Case 4. Kermit Gosnell. The House of Horrors on Lancaster Avenue. The Women's Medical Society Clinic on Lancaster Avenue in West Philadelphia occupied a particular and complicated position in its community. The neighborhood it served was poor, with significant immigrant and minority populations. Access to health care of any kind was limited. Kermit Gosnell had operated there for decades, presenting himself as a provider of services to people who had few alternatives. This positioning was his primary operational protections. It made the clinic difficult to scrutinize without appearing to scrutinize the community's access to care. It was, in retrospect, a shield he had constructed deliberately. When federal agents entered the clinic in 2010, initially on a tip about illegal prescription drug activity, what they found bore no relationship to any legitimate medical facility. The grand jury report produced after the raid was 281 pages. Its language, which was clinical and precise by legal necessity, still produced descriptions that investigators and prosecutors described as among the most disturbing documents they had ever encountered professionally. The physical condition of the clinic was the first thing every person who entered described. The air was thick with the smell of urine, disinfectant, and something else. Something biological, something decaying. The waiting room furniture was torn and stained. Cats roamed freely through the building. Cat feces were found throughout. The floors of the procedure rooms were stained with blood that had accumulated over years. Medical equipment was old, broken, and unsterilized. Surgical instruments that should have been processed through autoclaving between procedures were rinsed in a dirty sink. In the basement, investigators found bags, milk jugs, and cat food containers filled with biological material, fetal remains that had been stored, in some cases, for months or years. This was not a medical facility that had fallen into disrepair. It was a facility that had never been a medical facility in any functional sense. The staff Gosnell had assembled reflected the same disregard for any medical standard. His wife, Pearl, had no medical training and regularly performed procedures. Other employees, some with no education beyond middle school, were assigned clinical duties that required advanced training. Most infamously, a 15-year-old high school student was routinely assigned to administer intravenous anesthesia, giving powerful narcotics to patients without the slightest understanding of proper dosage, patient monitoring, or emergency response. Gosnell's primary practice was performing abortions well beyond Pennsylvania's legal limit of 24 weeks on women who were, in some cases, 7, 8, or 9 months pregnant. Many of his patients were poor, desperate, and had no other options they were aware of. The combination of late gestational age and the clinic's complete absence of sterile conditions or qualified staff created conditions in which serious injury and death were not aberrations. They were predictable outcomes. In 2009, Karnamaya Mongar, a 41-year-old refugee who had arrived in the United States just 4 months earlier, came to the clinic. She was given a sedative overdose by an untrained staff member. She went into cardiac arrest. The clinic's defibrillator was broken. No one on the premises was trained in CPR. Instead of calling 911 immediately, the staff waited, losing minutes that could not be recovered. She was dead on arrival at the hospital. The most serious criminal charges against Gosnell, however, were not for Karnamaya Mongar. They were for what his own staff described happening repeatedly when late-term procedures resulted in a live birth. According to the testimony of multiple staff members, it was routine for viable infants, breathing, sometimes crying, sometimes moving, to be delivered into a toilet or a pan on the floor. When this happened, Gosnell's standard response, witnessed and described by multiple employees, was to take the infant and sever the spinal cord with surgical scissors inserted into the back of the neck. He referred to this procedure, casually and repeatedly, as snipping. Staff estimated this happened hundreds of times. He kept severed infant feet in labeled specimen jars on a shelf in the clinic, not for any documented medical or research purpose, as trophies. At trial in 2013, Gosnell was convicted of 3 counts of first-degree murder for the infants he had killed after live birth, 1 count of involuntary manslaughter for the death of Karnamaya Mongar, and more than 200 additional charges including racketeering and performing illegal abortions. To avoid the death penalty, he gave up his right to appeal. He was sentenced to 3 consecutive life terms, plus additional time. He will die in prison. As of 2026, Kermit Gosnell is in his mid-80s, incarcerated at the State Correctional Institution at Huntingdon in Pennsylvania. The formal grand jury report condemned not only Gosnell but the Pennsylvania Department of Health and the state's regulatory apparatus for failing to conduct even basic inspections of the clinic for over 15 years, despite numerous complaints. This was not a case of a criminal hiding his crimes. It was a case of a criminal operating in plain sight in a community that the regulatory system had decided not to look at closely. Case 5. Martin MacNeill. The perfect murder. Almost. Dr. Martin MacNeill had constructed his life with the deliberateness of someone who understood, instinctively, that image was everything. He was a physician in Pleasant Grove, Utah. He was also a licensed attorney. He was a prominent member of his Mormon community, present, visible, and active. He was married to Michelle MacNeill, a former beauty queen, and they had 8 children. The family photograph was exactly what it appeared to be designed to look like, a picture of American success and domestic happiness. Behind all of it, MacNeill had been conducting a sustained double life for years. Serial adultery, conducted with the same discipline he applied to his public persona. His marriage to Michelle was a social and financial asset he had no intention of giving up through divorce. But his relationship with a younger woman named Gypsy Willis had, by 2007, reached the point where he had decided Michelle was in the way. A divorce would be expensive and socially damaging. MacNeill reached for a different solution. His first move was to persuade Michelle to have a facelift. Michelle was 50 years old, healthy, and had no particular desire for cosmetic surgery. MacNeill was persistent. He framed it as something she deserved, something that would help her feel better. She eventually agreed. The surgery itself was legitimate. What MacNeill was engineering was what came after it. Major elective surgery creates a medically legitimate reason for strong postoperative pain management. MacNeill, with his medical knowledge, understood precisely which drugs combined most dangerously. He personally instructed the plastic surgeon performing Michelle's procedure on which specific medications to prescribe, requesting an unusual and clinically problematic combination of Valium, Ambien, Percocet, and Finnergan. He was not requesting these drugs for their therapeutic value. He was assembling a formula. When Michelle came home from surgery, MacNeill took complete control of her recovery. He administered her medications himself. He crushed pills and mixed them into food and drinks. He kept her, his daughters later testified, in a state of semi-consciousness that went far beyond what postoperative recovery required. She was sedated to the point of being barely functional. His daughters grew alarmed. They had expected to see their mother recovering, and instead she was deteriorating. MacNeill kept them away from her care as much as possible. On the morning of April 11, 2007, 8 days after the surgery, MacNeill sent his youngest daughter, 6-year-old Ada, to a neighbor's house on an errand. When Ada returned, she found her father in the master bathroom. Her mother was in the bathtub, submerged, unresponsive. MacNeill's performance for the arriving paramedics was that of a panicking husband, but the paramedics and later, investigators noticed inconsistencies. The story he told about what had happened shifted. His demeanor, as described by multiple first responders, was not quite what they expected from a man who had just found his wife drowning. The medical examiner, finding the drugs in McKelly's system and no obvious signs of violence, initially ruled her death natural cardiac arrhythmia, complicated by the medications. To the outside world, it was a tragedy. A woman who had undergone elective surgery and suffered a fatal reaction to her pain medication. To Martin MacNeill, it was a success. He severely underestimated his daughters. At the funeral, held within days of Michelle's death, MacNeill was observed by multiple attendees laughing, socializing, and making casual remarks about his wife being in a better place. The behavior was noticed and disturbing to everyone who saw it. 2 weeks later, he moved Gypsy Willis into the family home. He introduced her to the younger children as their new nanny. His daughters, particularly Alexis and Rachel, were already suspicious. The nanny's arrival converted that suspicion into something harder, a determination. They began documenting. They researched. They discovered their father's history of affairs and the true identity of the woman now living in their mother's house. They contacted the Utah County Attorney's Office, repeatedly, insistently, with documented evidence of their father's behavior and their specific concerns about the circumstances of their mother's death. They refused to let it go. Their persistence eventually forced a reinvestigation. A new chief medical examiner reviewed the toxicology records and found that the combination and concentration of drugs in Michelle's system was not a tragic accident of post-surgical pain management. It was a lethal cocktail, present in quantities that would have left her physically incapable of saving herself. The manner of death was changed to undetermined. At trial in 2013, MacNeill's own children testified against him. In the absence of direct physical evidence of a struggle, the prosecution built its case on motive, means, and the weight of circumstantial evidence assembled across years of investigation. The daughters' testimony about their father's behavior before, during, and after their mother's death was central to the jury's deliberations. In November 2013, the jury found Martin MacNeill guilty of first-degree murder and obstruction of justice. He was sentenced to 17 years to life in prison. He lost his appeals. On April 9, 2017, he was found unresponsive in the prison yard at the Utah State Prison. He had taken his own life. Case 6. Janine Jones. The death shift. In the pediatric intensive care unit, the relationship between a nurse and a family is unlike almost any other in medicine. The parents of a critically ill child are terrified, sleep-deprived, and stripped of their normal competencies. They do not speak the language of the PICU. They cannot read the monitors, or interpret the lab values, or understand the significance of changes in their child's condition. They depend entirely on the nurses around them, not just for information, but for reassurance, for someone to tell them what is happening and whether their child is going to survive. The nurse who is present, who is calm, who responds quickly to emergencies, who seems to know what to do, that nurse becomes enormously important to those parents. Their gratitude is profound. Their trust is absolute. Janine Jones understood this perfectly, and she exploited it in the most monstrous way imaginable. Jones was a licensed vocational nurse at Bexar County Hospital in San Antonio, Texas, in the early 1980s, working the pediatric intensive care unit. She was known for her ability to handle the high-pressure life-or-death urgencies that defined the unit's daily reality. She responded fast. She was composed during crises. She seemed to thrive in the adrenaline environment of a code blue. What her colleagues began noticing, and what took much longer to formally document and act upon, was the statistical impossibility accumulating around her. Infants and children on her shift were suffering sudden, unexplained cardiac events and uncontrollable bleeding episodes at a rate that had no parallel in the unit's history. The pattern was specific. It happened on the 3 p.m. to 11 p.m. shift. It happened on the shift that Janine Jones worked. Her colleagues called it the death shift. Jones's method was deliberate, targeted, and pharmacologically precise in a way that required specific knowledge to execute. She would secretly administer succinylcholine, a potent muscle relaxant that shuts down the respiratory system within minutes, to pediatric patients who had not been prescribed the drug. She would also administer heparin, a powerful blood thinner that, in excess quantities, causes catastrophic internal bleeding. She would inject these drugs covertly into IV lines and then wait. When the child's monitors alarmed and the room collapsed into emergency response, Jones was always the first at the bedside. She would perform resuscitation dramatically and skillfully. Sometimes she succeeded and the child recovered. Sometimes she did not succeed and the child died. Either way, she received what she had sought: the visible status of the nurse who responds to emergencies, the gratitude of parents, the recognition of colleagues. When children died on her watch, the cause was attributed to the inherent fragility of critically ill infants. The PICU lost patients. That was the nature of the environment. Nurses on the unit went to hospital administration, not with vague concerns, with documented statistical evidence that the death rate on Jones's shift was a pattern, not a coincidence. The hospital's response was institutional cowardice at its most catastrophic. Rather than contacting police, the administration conducted an internal review. Rather than alerting any external authority, they quietly asked their vocational nursing staff, including Jones, to resign. They allegedly shredded documentation related to the investigation. They allowed a nurse who had almost certainly been killing children in their hospital to walk out the door, take her skills and her compulsions, and find new patients. In 1983, Jones took a position at a small private pediatric clinic in Kerrville, Texas, run by a physician named Dr. Kathleen Holland. Within a month, 6 children who had received routine vaccinations from Jones suffered sudden, life-threatening emergencies. After the death of 15-month-old Chelsea McClellan, following an injection from Jones, Dr. Holland found puncture marks on a vial of succinylcholine in the clinic's drug cabinet. Succinylcholine had no legitimate clinical use in that office. She took the evidence directly to police. The subsequent investigation was complicated by the same pharmacological property that had made Jones difficult to catch. Succinylcholine metabolizes rapidly in the body and becomes nearly undetectable within hours. The evidence window was narrow, and the forensic challenges were significant. In 1984, Jones was convicted of the murder of Chelsea McClellan and sentenced to 99 years in prison. A separate trial produced a 60-year sentence for the near-fatal heparin overdose of another child. She was suspected of murdering as many as 60 infants and children. The case could only be built solidly around one. The story should have ended with 99 years. It did not. A Texas mandatory release law, designed to address prison overcrowding, meant that even a 99-year sentence triggered automatic parole eligibility at a specific date. Jones was scheduled for mandatory release in March 2018. The families of her victims were notified. Prosecutors who had put her away were notified. The response was a race against time. A new prosecutorial team reopening the cold cases from the 1980s, reviewing old evidence, tracking down witnesses who had moved on or aged across the intervening decades, trying to construct a new case solid enough to keep her behind bars. In January 2020, Jones pleaded guilty to the 1981 murder of 11-month-old Joshua Sawyer, a child she had poisoned with a toxic overdose of an anti-seizure drug. The plea earned her an additional life sentence. As of 2026, Janine Jones is 74 years old and remains incarcerated in a Texas state prison. Halfway through the list, and I want to take a moment. The cases we're covering today span nearly a century, from a nurse murdering infants in a Texas PICU to a Nazi doctor who operated a human experimentation program at Auschwitz. The range is deliberate, because the point is not that these are exceptional people. The point is that the credential, the license, the white coat, the structural authority that medicine gives its practitioners, can be weaponized by anyone willing to use it that way. Daily Crime Archive is still a new channel. We cover cases like these because they deserve the depth of coverage we're giving them, and because the victims deserve to be more than a footnote. If you haven't subscribed yet, now is the time. Check the pinned comment after this video for a full status update on every case covered today. And leave us a comment. Which of these cases have you followed? Which one are we covering in a way you haven't heard before? 4 more cases. Let's finish the list. Case 7. Conrad Murray, the doctor who killed the King of Pop. In 2009, Dr. Conrad Murray was a cardiologist with practices in Las Vegas and Houston. By the standards of his profession, he was successful, established, credentialed, and operating a busy clinical practice. He was not wealthy in the way that proximity to celebrity could make a person wealthy, but he was doing well. Then the call came. Michael Jackson needed a personal physician for the final rehearsal period of his comeback tour. 50 planned concerts in London, billed as the largest and most ambitious live event of his career. The salary being offered was $150,000 per month. Conrad Murray accepted. What the job actually required was something that no ethical physician should have agreed to. The administration, nightly, of propofol, a powerful intravenous anesthetic used for surgical procedures in hospital operating rooms, as a treatment for Michael Jackson's chronic insomnia. Propofol is not a sleep aid. It is a drug that induces unconsciousness. The distinction is not semantic. It is clinical, and it is critical. A patient under propofol is not sleeping. They are unable to maintain their own airway, unable to respond to stimuli, and dependent on continuous monitoring and immediately available emergency equipment to survive any complication. Administering propofol outside a hospital setting, without an anesthesiologist, without cardiac monitors, without a defibrillator, without oxygen, is not aggressive or unconventional medicine. It is not a gray area. It is gross medical negligence by any standard that exists in any licensing jurisdiction. Murray did it anyway. Night after night, in the master bedroom of a rented Bel Air mansion, he connected an IV, pushed propofol into the line until Jackson lost consciousness, and monitored him with the fingertip pulse oximeter he frequently didn't watch. He was playing Russian roulette with the life of the most famous entertainer in the world. He played it, by his own account, for approximately 2 months before the chamber came uploaded. On the morning of June 25, 2009, Murray had administered a series of progressively stronger sedatives over several hours, as Jackson struggled to fall asleep. None of them worked. At approximately 10:40 a.m., he administered propofol. Phone records produced during the subsequent investigation told a story substantially different from Murray's account to police. He told investigators he had left Jackson's side for only 2 minutes to use the bathroom. Phone records showed he had been on his phone, calls to his girlfriend, calls to his medical practice, text messages, for an extended period while Jackson lay unconscious with propofol in his system. When Murray finally returned his full attention to Jackson, he was not breathing. Murray's first response was not to call 911. It was to begin gathering the vials of propofol and other drugs and concealing them, removing evidence of his own practice before emergency responders could see it. He then attempted CPR but performed it incorrectly, on a soft bed, with one hand, in a manner that could not have been effective. He had no defibrillator. He had no oxygen. 25 minutes after finding Jackson unresponsive, a security guard was finally instructed to call for help. When paramedics arrived, Murray lied to them. He described the medications Jackson had received while omitting the propofol, withholding the single most important piece of clinical information the emergency team needed to attempt resuscitation effectively. Michael Jackson was pronounced dead at UCLA Medical Center. He was 50 years old. The toxicology report confirmed a lethal concentration of propofol in Jackson's system. The stashed medications were recovered. The phone records documented Murray's activity during the period when Jackson was dying. At trial in 2011, Murray was convicted of involuntary manslaughter. He was sentenced to 4 years in county jail. He served 2, released early under California prison overcrowding provisions. As of August 2026, Conrad Murray remains in the medical community's record as a cautionary case study. His medical licenses in Texas, California, and Nevada were revoked or suspended. He has not practiced medicine since. The case raises a question that goes beyond Conrad Murray specifically. What happens when the physician-patient relationship operates in an environment of extreme wealth and power disparity, where the patient's demands override clinical judgment and the physician's financial dependence on the patient erodes every professional boundary? It is not a hypothetical question. It is a documented dynamic, and it recurs wherever celebrity medicine operates without institutional oversight. Case 8. Anthony Garcia, 7 years of waiting. Most medical careers involve setbacks. A difficult supervisor. A residency program that isn't the right fit. A performance review with criticism that stings. Professionals absorb these experiences, adjust, and move forward. Dr. Anthony Garcia did not move forward. Garcia's path through medical training was marked by repeated conflict, complaints from supervisors about his conduct and attitude, and a trail of programs that had asked him to leave. In 2001, that trail led to Creighton University Medical Center in Omaha, Nebraska, where he was terminated from the pathology residency program. The termination letter was signed by 2 doctors, Dr. William Hunter and Dr. Roger Brumbach. For Garcia, these 2 men became something more than administrators who had fired him. They became the symbols of every failure, every humiliation, every opportunity that had not materialized. He fixated on them with an intensity that did not diminish over the years that followed. It grew. 7 years later, he acted on it. In March 2008, Garcia drove to Omaha and broke into the home of Dr. William Hunter. Dr. Hunter was not there. Inside the house were Hunter's 13-year-old son Thomas and the family's 57-year-old housekeeper, Shirley Sherman. Garcia stabbed them both to death. He staged the scene to resemble a home invasion robbery and left. The crime was horrifying and seemingly inexplicable. A respected pediatric pathologist's son and a family housekeeper, killed in an upscale home with no apparent motive. Investigators had no suspects and no thread to pull. For 5 years, the murders went unsolved. In May 2013, Garcia returned to Omaha. This time, Dr. Roger Brumbach, by then the chief of pathology at Creighton, was home. Garcia killed him and his wife Mary in the same manner, stabbed to death, the scene staged to suggest robbery. The second double homicide changed the investigative picture entirely. 2 crime scenes. Identical method. Both victims connected to the Creighton University Pathology Department. The pattern was not subtle once it was visible. Investigators immediately linked the 2013 killings to the 2008 murders and recognized that this was not random violence. This was a targeted campaign. They pulled determination records from Creighton's pathology residency program going back 20 years. They assembled a list of every resident who had been dismissed. One name appeared in connection to both Dr. Hunter and Dr. Brumac: Anthony Garcia. A national manhunt followed. Garcia's digital footprint, cell phone records, financial transactions, location data, placed him in Omaha during both sets of murders. He had called a local restaurant on the day the Brumbacks were killed. 2 months after the second murders, Garcia was stopped for a routine traffic check in southern Illinois. He was intoxicated. In his car, a .45 caliber handgun and a high-capacity magazine. He was arrested. The trial was built on circumstantial evidence. Garcia had been meticulous enough about staging the scenes that no direct physical evidence linked him to the killings. But the circumstantial case was overwhelming in its coherence. The history of grudge, the timeline placing him in Omaha during both crimes, the phone records, the financial records, the pattern that pointed to one person with one specific motive. In 2016, the jury found Garcia guilty on 4 counts of first-degree murder. He was sentenced to death. As of 2026, Anthony Garcia sits on death row at the Nebraska State Penitentiary. Case 9. Christopher Dunch. Dr. Death, Christopher Dunch, arrived in Dallas with a curriculum vitae that appeared impressive and a manner confident, assertive, self-promoting that is not uncommon in surgical specialties. He claimed an MD and PhD, a research background, and a career that suggested significant expertise in spinal surgery. What he actually brought to Dallas was something the hospitals that granted him operating privileges failed to discover until the damage was done. Surgeons and nurses who were called into operating rooms where Dunch was working described what they witnessed in terms that shifted, for many of them, from professional concern to something closer to horror. He operated on the wrong sections of the spine. He severed major arteries. He drilled screws into muscle tissue rather than bone. He left surgical instruments inside patients. He damaged nerves that did not need to be touched. The 2 most stark individual examples from his time in Dallas. He permanently paralyzed his own childhood friend, a patient who had trusted him specifically because of their personal history, by severing a vertebral artery during a procedure. The surgical destruction was so severe that no subsequent intervention could restore function. During one procedure, an assisting surgeon physically reached over and removed Dunch's instruments from his hands mid-operation to prevent him from continuing to harm the patient on the table. In less than 2 years operating in the Dallas-Fort Worth area, Dunch operated on 38 patients. 33 were left with permanent, life-altering injuries. 2 were killed. The system that should have stopped him failed at every level at which it could have intervened. When the first hospital, Baylor Plano, revoked his operating privileges after he had damaged multiple patients, they did not report him to the National Practitioner Databank, the federal system designed specifically to track physicians who pose dangers across different institutions. Instead, they provided him with written documentations, stating there were no issues with his performance. He took that letter to Dallas Medical Center and used it to obtain a new position. It was there that he killed his second patient, a 63-year-old woman named Floella Brown, whose death resulted from a combination of surgical errors so severe they were described in subsequent litigation as defying any competence-based explanation. The physicians who ultimately stopped Dunch were not hospital administrators or medical board investigators. They were 2 surgeons, Dr. Robert Henderson and Dr. Randall Kirby, who had been called in repeatedly to attempt repair of the damage Dunch had caused to his patients. What they saw in those repair operations spinal structures fused in wrong positions, hardware placed in anatomically impossible locations, evidence of damage that could not be explained by surgical inexperience, led them to a conclusion that went beyond incompetence. They described Dunch to investigators and to the medical board as someone who appeared to know what he was doing. The damage he caused was not the damage that results from a surgeon who doesn't have the skill to do what they're attempting. It was damage that required skill to inflict. Their sustained personal campaign letters to hospitals, calls to the Texas Medical Board, formal complaints filed and followed up, eventually forced the board to suspend Dunch's license in June 2013. The Dallas County District Attorney's Office then took the rare step of pursuing criminal charges. The prosecution argued that Dunch's actions constituted intentional assault rather than malpractice. In 2017, Dunch was convicted of injury to an elderly person for the surgical destruction of 74-year-old Mary Efford, who was left permanently paralyzed. The judge sentenced him to life in prison. As of 2026, Christopher Dunch is incarcerated at the Texas Department of Criminal Justice. Case 10. Yosef Mengele, the Angel of Death. Before the war, Yosef Mengele appeared to be building a legitimate and distinguished academic career. He was the son of a wealthy German industrialist. He held 2 doctorates, one in medicine, one in physical anthropology. He was intelligent, disciplined, and moving through the academic world in a trajectory that, under different circumstances, might have led to a professorship, a research institute, a career measured in publications and grants. The different circumstances were the ideology that Mengele had absorbed and made the foundation of his intellectual life, the racial pseudoscience of National Socialism, with its taxonomy of human beings into categories of the valuable and the disposable. He was not a passive adherent. He was, by all accounts, a true believer. When the war came, and the machinery of the Nazi state began operating its extermination camps, Mengele saw an opportunity. In 1943, he was transferred to Auschwitz-Birkenau. At Auschwitz, Mengele performed selections on the train platform as new transports of prisoners arrived. Standing in his SS uniform, often described by survivors as whistling opera, he would survey the newly arrived prisoners, men, women, children, the elderly, and direct each one with a gesture of his hand or a turn of his finger. Left, immediate death in the gas chambers. Right, slave labor until death from exhaustion, disease, or further selection. He performed these selections, by his own participation, hundreds of times. But selections were administrative functions that other SS physicians also performed. What distinguished Mengele at Auschwitz was his medical research program, a sustained program of human experimentation conducted on prisoners who had no ability to refuse, performed without anesthesia, and justified by pseudoscientific frameworks that served no legitimate research purpose. His primary subjects were twins. He had his guards identify twins from every incoming transport. These children, and they were mostly children, were housed separately from the general population and subjected to experiments that Mengele conducted personally or supervised. He would infect one twin with a disease pathogen and use the other as a control. When the infected twin died, he would kill the healthy twin with a direct injection of chloroform into the heart so that he could perform simultaneous autopsies and compare the organs. He attempted blood transfusions between twins of different blood types. He attempted to surgically create conjoined twins. He injected chemicals directly into children's eyes, attempting to alter their color, a procedure that caused immediate and severe pain, infection, and frequently permanent blindness. His experiments extended to dwarfs, to people with physical abnormalities, to any subject whose biology could be framed, within the ideological apparatus he operated under, as research material. None of it had genuine scientific value. The methodologies were not scientific. The record-keeping was not scientific. The conclusions were not scientific. What the experiments represented was the sadistic exercise of total power over the bodies of human beings who had been designated by law and ideology as non-persons. the application of a medical credential and a laboratory setting to what was, in its essence, torture and murder. When the Third Reich collapsed in April and May of 1945, Mengele fled. He was briefly captured by American forces in the chaotic final weeks of the war, but was released without his identity being established. Using a network of former Nazis and sympathizers, the so-called rat lines, he escaped Germany, eventually reaching Argentina and then Paraguay and finally Brazil, where he lived for decades under assumed identities. The global pursuit of Mengele involved Nazi hunters, the Israeli intelligence service Mossad, West German authorities, and various investigative journalists and private individuals. The pursuit was sustained, but ultimately unsuccessful. Mengele was extraordinarily careful, well funded by his family in Germany, and protected at various points by political regimes that were not eager to pursue him. He was never brought to trial. On February 7, 1979, living under an alias in the coastal Brazilian town of Bertioga, Mengele suffered a stroke while swimming in the ocean and drowned. He was 67 years old. His remains were exhumed in 1985. Forensic and DNA analysis confirmed his identity. He died on a beach in Brazil. He was never forced to account for what he had done to the twins of Auschwitz, to the hundreds of thousands he directed to the gas chambers with a gesture of his hand, to the prisoners whose bodies he treated as laboratory equipment. As of August 2026, Josef Mengele remains the most extreme example in modern history of what can happen when medical authority is placed in the service of an ideology that has stripped the subjects of that authority of their humanity. His case is not comparable to the others on this list in terms of scale, context, or the systemic machinery that enabled it. The Holocaust was not one doctor's crime, but Mengele represents something specific. The endpoint of a trajectory that begins when the barrier between patient and research subject, or patient and obstacle, is removed by someone holding a medical credential. The white coat is not a guarantee of anything. It is a symbol of a trust that has to be continuously earned. These 10 cases are 10 instances of that trust being betrayed. That's all 10 cases. If you're still here, thank you. Content like this takes time and research to do properly. And the fact that you stayed is exactly why we keep going. Daily Crime Archive is a new channel. That means your subscribe, your share, and your comment below carry real weight in how this channel grows. Hit subscribe if you haven't. Turn on the bell. Drop a comment telling us which of these 10 cases you knew going in, and which one changed what you thought you knew. Check the pinned comment for the full status update on every case covered today, where each person is as of August 2026, what happened after the verdict, and what the systemic outcomes of each case were. We'll see you in the next one.